You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. Landrum, welcome to the Nailed It Ortho Podcast. So happy to have you on. So welcome to the podcast.
Thank you very much. It's a pleasure to be here. I appreciate you having me.
And we were briefly talking, before we started, but I'm glad this is your first podcast. I'm glad it's on Nailed It Ortho. So, I'm excited that you chose to share this moment with us. So again, really looking forward to this talk.
Same here. Thank you. It's funny because whenever you do something out of the box like this, that's your norm, you actually get a little nervous still. It's been standing up and lecturing and talking a lot and been at podiums, but yeah, still get those butterflies. So thank you for having me.
Oh, no problem. And we always start off with just a couple questions, just, getting to know our guests a little bit better. And we have a lot of residents that listen to this podcast, some medical students as well. But what kind of drove you into the field of like pediatrics at all the different specialties? What kind of made you, like, the story behind you choosing pediatrics?
So it really was out of nowhere. I did my residency up in Dallas at Parkland and UT Southwestern, and I was going to do joints. And then during our third year, we get to rotate over at Texas Scottish Rite, and it's a phenomenal program. And I had not had much exposure to pediatric orthopedics other than random children's calls and doing some reading, or exposure to kids really. So then I rotated over at Texas Scottish Rite under the assumption that that was going to be the first and last time I ever do pediatric orthopedics. And after my first month, I was hooked. I started there not only doing trauma stuff, but also working with Dr. Richards, who does a lot of scoliosis. He retired, but he was doing a lot of scoliosis, and then Dr. Kim doing a lot of Perthes and hip stuff. And I just thought it was fascinating. And that just grew over the entire 6 months at Texas Scottish Rite. But by far the best thing about this job is working with kids that they heal well, they want to get better, and they're just a joy in the clinic.
Yeah, I had a really, really fun time on my pediatrics rotation. I was like, oh, this is actually kind of cool, like working with the kids and how they just heal. They'll have a bad, for both on forearm fracture, and then like in a couple months, it's like it was nothing was even there. It was a really, really good time. And one of the other things that you mentioned is I realized a lot of people, when they come to how they choose their different specialties, a lot of people will mention like their mentors that they had in that specialty that kind of helped drive that decision. I know you kind of mentioned some of your mentors or faculty that you worked with as well. And that being said, what if you had to go back and give yourself one piece of advice? We'll make it a two-part question. So one piece of advice starting residency, and then one piece of advice when you started maybe your fellowship. What would you go back and say to your younger self?
That's a really good question. And two things come to mind. Residency is not just 5 years. It's a lifelong process and commitment, and the relationships you have within residency. You mentioned mentors. There are still people that I trained with in residency and fellowship that I talk to on a weekly, if not sometimes daily basis. So it's not just an isolated 5 years. It's a lifelong process, and the relationships you make are going to come in for the rest of your life. And this other one's going to sound really negative, but it's not.
All right, let's do it.
A lot of people will tell you it gets better. It doesn't. It never gets better. It just gets slightly different. Okay. You're like, when you're an intern, you're like, it's going to be better whenever I'm not an intern anymore. Second year, it's going to be better when I'm not a junior resident, better when I'm a senior resident, better when I'm a fellow, better when I'm a staff. It just gets slightly different. So really, it took me a while to realize that enjoying the journey is what it's all about, right? You're going to have different struggles at different points within your career, and embracing them, diving headlong into them, and then learning from them are huge things that help you succeed.
Yeah, no, that is a great piece of advice. And I remember, I think I was listening to maybe a football coach, and they were kind of had a similar analogy, and everybody's always focused on a championship, but it's more kind of enjoying the journey, just like you were just saying with residency. So for those listening, remember that just enjoy where you're at now and enjoy the process. And so that being said, I guess we can go and switch transitions and talk a little bit today about scoliosis, early onset scoliosis. We have an episode before that just talked over adolescent idiopathic adolescent scoliosis, but this is completely different. And we're going to talk about early onset scoliosis. And I guess just starting off, what exactly does the term mean? Like, what exactly is early onset scoliosis?
Yeah, and this is also slightly controversial, like
Okay.
everything we're going to talk about for the next hour. So,
All
you know,
right.
when looking at this for OIT and boards, there are very specific things, and then you can get into the nebulous, really interesting stuff about early onset scoliosis. But it is quite nebulous because there's a lot of nuance to it, and there's multiple different answers for one issue. But early onset scoliosis is actually not a diagnosis. It's kind of a blanket term. And it's any patient with a coronal Cobb angle greater than 10 degrees who's younger than 10 years old. So 10 degrees younger than 10 years old. But it's not a diagnosis because, right, you look right here, congenital scoliosis, infantile, and juvenile, those are your diagnoses, not early onset scoliosis.
Okay. So in general, people younger than 10 with greater than 10 degrees of curve on the Cobb angle and in the coronal plane, and we'll touch base on that in a bit as far as imaging. So I figured what we could do is we could maybe just start in chronological order, and we could talk about about congenital scoliosis, which you're just saying is a diagnosis. So I guess why does congenital scoliosis happen, or what's this etiology, and can you kind of explain or break down what this is?
That is a great question because we don't know. We think it's,
Perfect.
you know, sometimes it can be genetic. It can be associated with other diseases like you see here, Vater, Vactero, Klippelfeil, those types of things. We think it may be due to a vascular issue in utero. You know, there's, you know, the first trimester in utero, you know, the 5 to 8 week-ish range. And that's why whenever you see a patient with congenital scoliosis, or you see a hemivertebrae or a bar or something like that, alarm bells need to start ringing and the red flag needs to come up, because you kind of need to dive a little bit further into the non-ortho things that can be very significant.
Yeah, and some of the things that you just mentioned, you mentioned like a hemivertebra and a bar, and so what are these things? I remember doing questions and like having not looked at this ever at all, and I would see those as the answer choices, and like I have no idea what I'm looking at. I have no idea. I'm just gonna go ahead and pick C and continue on. So what is, you know, what is this bar and a hemivertebra, and I guess what kind of causes these?
And so this picture you have here is the perfect one that actually years ago made me understand congenital scoliosis, because I was the same way. I said, what do you mean failure of formation versus segmentation? What does that even mean? But this really breaks it down very well. And at the top you see those defects of segmentation, right? Each vertebrae is a different segment, and so if they don't separate and have those disc spaces in between, that creates a tether. And so you can see all the way to the left, those block vertebrae, it's basically going to be one big block. And so there's a relatively low risk of a significant spine deformity compared to these other ones, because it's one big block. They might have a completely straight spine with just a couple fused vertebrae.
Yeah.
And so then the unilateral bar starts becoming a problem because it's only one side. So when you look at that picture and you think, okay, just that right side of the picture, there's not as much growth happening because the end plates or the growth, the physes aren't growing appropriately like they are on the left side. And so that's why that left side is going to grow more and grow into that curve. And so you'll have that concavity where there's a bar and the convexity on the other side, because that other side is growing appropriately. And then it starts getting a little bit more tricky. We'll jump down to the bottom where it's a defect of formation, and that's a hemivertebrae. And they've got multiple different kinds of hemivertebrae, but just knowing in your mind, is it a bar or is it a hemivertebrae? So part of the vertebrae is growing, but not the whole thing. And so that creates a wedge and acts kind of like a fulcrum pushing the spine over. On the bar, it's tethered, so it's not going to grow. Whenever it's a hemivertebrae, it's only growing on half of it. So it's pushing you into a scoliotic deformity. And so you've got multiple different kinds, the fully versus semi-segmented, the incarcerated, non-segmented, all those kind of things. But the main thing is there a hemivertebrae? And those are a little bit easier to see, or is there a bar? But the really bad ones are the bar on one side, so it's holding everything still and not allowing it to grow, and then a hemivertebrae on the other side. So you've got a tether plus a driving force. So those are the ones that typically get bad the quickest.
Yeah, and I love how you explain that. You explained that so well. And just to do a quick recap, so you talked about the block vertebra, where those, these vertebrae just fused. They haven't segmented. Versus if you have it just on one side, that's what we call a bar. So that's creating a tether, like you said. So you have a tether on one side. Versus if you have a hemivertebra, you have like this wedge that's just pushing, because only one side of the vertebra is growing, so it's pushing the rest of the spine in the other way. So the worst one, pretty much, where you have almost what they say like 100% risk of progression, is when you have a unilateral bar on one side, which is that tether, and then on the other side a hemivertebra, which is going to just grow and push the spine just to curve, way more in one direction, basically.
Exactly. And the most important thing to remember whenever this pops up on your OIT and boards: kidney, heart, other things. It's funny how that works, but whenever they pop these up, a lot of times they're looking for, are you thinking vectoral and renal abnormalities and those types of things. So they all develop right around the same time in utero.
So if we see this, you also definitely need to make sure there's not other things going on with the patient, with the child or newborn or whatever it may be.
Exactly.
Yeah, go for it.
No, they're trying to drag you down that path of, okay, look at other non-ortho things and potentially get an MRI. Those are kind of the two paths they want you to go down.
And speaking of imaging and MRIs, this patient has congenital scoli. What imaging do you get? You talked about an MRI. Do you get X-rays as well? And then what are you looking for on these different films? And maybe we can touch base about congenital a little bit, maybe EOS in general, as well as the different imaging to get.
Yes, I always start with X-rays, a PA and lateral full spine radiographs like you see here. And then you're able to assess not just the spine, but you're also able to assess the rib cage as well, which I know we'll probably talk about thoracic insufficiency, those things in a little bit. But you can see all those things, as well as whenever they get a little bit older and it's a standing radiograph as opposed to, a 1 or a 2-year-old, you need them supine because they can't stand or they can't really follow directions. I also like to make sure that they don't have a limb length discrepancy that's causing a slight scoliosis in the lumbar spine, because that can happen too from a limb length discrepancy. And so is it the chicken or the egg? You need to kind of figure out, is this, they have one leg longer than the other creating a curve down there, or is there a curve creating pelvic obliquity like you see here in your X-ray? So I always, I agree, I start with plain radiographs, and then that brings us down, okay, do we need to get any advanced imaging? And it also helps with your treatment plan.
Yeah. And then so on your APs, you're basically looking for the Cobb angle. And then on your laterals, do you draw the plumb line, or what are you necessarily looking at on your lateral? Are you just kind of looking at their overall, do they have kyphosis, or, what is in your eyes, what are you looking for?
A few different things. So I'm definitely looking at the sagittal contour. Are they hyper or hypokyphotic? Are they having issues with lumbar lordosis? Do they have do they have flat back? Do they have some type of shift of, like you said, the plumb line? Are they shifted forward? Are they shifted back? Anything like that? Because when it comes to Idiopathic scoliosis, a lot of times it's going to be a hypokyphotic deformity, especially in the thoracic spine. So I'm looking mostly at just the sagittal balance. And if you notice that there's a scoliotic curve with a lot of kyphosis, you worry about that, because a lot of times the idiopathic scoliosis will be hypokyphotic.
Okay, yeah, that makes sense. And one of the other things that they always mentioned in questions was the RVAD, and they never spelled it out for me. And I remember as like a first year going through questions, and I heard about the Cobb angle, so I was confident in that, but I never heard about this other angle, and it confused me every time. So I'm sure there's some other people listening to this that are very confused about what this RVAD, or the rib vertebral angle difference is. Can you kind of talk about that and maybe its importance, and then when do you measure this? Because I don't necessarily remember measuring this when we're talking about adolescents, but maybe we do in kids when they're younger.
Yes, it's for younger kids, exactly, for infantile idiopathic scoliosis. So this isn't necessarily a kid that has a hemivertebrae or a bar, but if you have that kid that's 0 to 3 years old that comes in with a scoliotic deformity, then your two things. Well, you look at Cobb angle, absolutely. A larger Cobb angle is worse, and then you look at the rib vertebral angle difference. And the key here is that word difference, because you're going to measure from the rib to perpendicular to the end plate, and then you measure the contralateral rib of the same level. And you can see here, and whenever there's a scoliotic curve, sometimes they look like they're mismatched, but you want to make sure you're at that same level. And then if there's a greater than 20-degree difference of that angle, then it's a risk of a progression. And then the phase ribs that you have just below this, where they're either not overlapping or they're overlapping, a phase 1 or a phase 2 rib, that's another indicator that this is high risk for progression. And what I think of is, why would that rib be overlapping that vertebral body? And the answer is rotation. It's a rotational deformity, right? And so if it's more rotated, and that's more of a view from like an axial CT scan or an MRI, so not really one that we can see very well on plain imaging. But if you look and you see that rib overlap, in my mind, that's a surrogate for a rotational deformity. And so that's why if there's more rotation, they're at higher risk of progression. And so this is telling me, okay, if they've got a question stem, or when I'm seeing a patient in clinic and they've got a greater than 20-degree RVAD, or they've got a phase 2 rib and their curve is greater than 30 degrees, this is a kid that I need to treat. I need to treat in a cast, or some kids will be in a brace. It's not one that you can just do some benign neglect and take another Xray in 3 to 6 months and expect it to be better. Which, if they don't have an RVAD greater than 20, phase 1 rib, and their scoliosis is 20-25 degrees, I would not do anything and say, okay, we can watch this, see them in a few months, take another Xray. But with all of those other risk factors, I would talk to them about a cast.
Okay. So just to summarize, we have our plain X-rays where, we're looking at their coronal plane alignment, you're looking at the Cobb angle, and then your laterals where you're looking at their sagittal plane alignment. And then here on a CT scan or an MRI, we're looking at the rib vertebral angle difference, and that's going to help us measure our rotation. So,
this is on an AP. This is on a plain X-ray.
Oh, on the plain X-ray. On the plain X-ray.
Yes, sir.
We are we got our rib RVAD, and that's going to help us measure the amount of rotation. And so, do you pretty much get an MRI on everybody with congenital scoliosis? And then if you do, what are you looking for?
Yes. So the rule here is that they're younger than 10 years old and they've got scoliosis, the answer you click is they need an MRI. Yeah. Because there's such a high risk that there's something else going on, and that's the Chiari malformation, syrinx, tethered cord or split cord. So all of those things are associated, and it depends on who you read. But you can kind of just say, okay, about 20% of, so about 1 in 5 of these kids will have one of these things.
Okay.
Some people say it's down in the teens. Some people say it's more like 30%. And so just knowing that it's significant means that we need to get an MRI on these kids. So any kid younger than 10 years old with scoliosis, you should be leaning towards getting an MRI. That being said, what do I do in practice? I'll have a discussion with the patient and the parents, because a lot of these kids will need MRIs under sedation. And I don't take sedation or anesthesia lightly in these kids. And so some of them have got a pretty small curve, less than 20 degrees, in between 10 and 20. I may see them back in a few months and take another Xray. And
Yeah.
if it's the same and it hasn't progressed at all, then we all kind of have a discussion together and joint decision making, say, should we pursue the MRI or should we hold off? And if there's any sign of progression, then we jump to the MRI. It also lets you get to know the kid and the parents a little bit more, because there's a lot of rapport that you need to build whenever you're going to be seeing these kids for 10, 15 years and getting to know their parents as well.
Yeah. Yeah. That makes total sense. And so, we talked about congenital scoliosis, and you have to definitely be on the lookout for other things, other congenital anomalies that may be going on. Any difference between when we're looking at like infantile, less than 3 years old per se, or juvenile scoliosis that like we need to know specifically, like, oh, when you think about infantile, you should think about this, and when you think about juvenile, maybe you need to consider these factors?
Definitely. So when it comes to infantile, that's where your RVAD and your phase ribs will come in. And so those are where you're saying, and definitely an MRI there.
Yeah.
And that's when you're saying, okay, should I treat this or not treat this, and just observe it. Whenever you're getting a little bit older into the juvenile area, still an MRI, and still looking at kidneys, heart, and a lot of times they'll have, if they've got Vata or Bacterial and they have the anal atresia or the esophageal issues, those will be noticed way earlier, right? Because those are kind of things that you need to be compatible with life.
Yes,
and so
it's very true.
The scoliosis comes along with that, but those things would be known before. But in the case of where they show up to your clinic with some scoliosis, they might have something like a horseshoe kidney, or a PFO, something a little bit smaller. I say that smaller, that's it's still a renal or a heart issue, but they can also have, the radial deficiencies or the extremity deficiencies too, but those would all be noticed. This is where whenever they start getting a little bit older, I still worry about those things, but I worry more about something within the cord, like a syrinx or a Chiari, or a tethered cord.
Okay. Yeah. That makes sense. And so I guess one of the other questions on the other side of things, in some of the developing countries or people that don't necessarily have access to healthcare, what happens when this goes untreated? Like the scoliosis, we'll just overall just give it a whole blanket, or congenital or infantile scoliosis just goes untreated. So what's the natural progression in that case?
It's very poor. And like you had on the last slide, and your spine grows rapidly within the first 5 years. And spine growth is kind of bimodal. It's that first 5 years, you've got a huge increase in your spine height and the room within your thorax for your lungs, because you need those alveoli to develop in the first couple years of your life to allow for your ability to have respiratory function when you're an adult size. And so whenever you start getting significant scoliosis, 80, 90, 100 degrees, and it starts really impacting your thoracic cavity, as well as you can have rib issues. You can have rib fusions or the collapsing parasol deformity that is in the SMA and neuromuscular population. That has a twofold issue when it comes to this term thoracic insufficiency syndrome, not only from within where there's not enough alveoli and they don't have the room and they kind of get almost equivalent of an emphysema type issue, but also the ribs aren't functioning appropriately. And there's not enough space in the thoracic cavity. So that's whenever they start going down the path of thoracic insufficiency. So they cannot get enough air exchange or oxygen exchange to support the rest of their body. And so that's why it is associated with significant morbidity and mortality, that these kids with, they did studies a while back that looked at mortality rates of kids with the younger kids with scoliosis versus kids with AIS. And there's a significant higher mortality rate in the younger kids with scoliosis compared to a normalized mortality rate in kids with AIS and older kids. So that's where you have the cardiopulmonary issues, the respiratory issues, that can cause the long-term problems. And that's why thoracic insufficiency and early onset scoliosis we've made huge strides in the treatment of this, but we're still working because there's a lot of issues with hardware and things long-term that we can talk about more. But that's why, like you said, in the developing nations, and if things go if they're left untreated, they can have a lot of issues as they age.
Yeah, and with the thoracic, every picture that pops in my mind every time is, at least when I've seen on slides, has been patient that has really bad scoliosis and a bunch of fused ribs. Like, are you seeing the fused rib? Is that like very commonly associated with the thoracic insufficiency syndrome?
Yes, it can be, and it depends on the syndrome. Okay. And then kind of where you are in the nation and the world as well. And so that's why taking care of those with thoracoplasties and sometimes even having to instrument the ribs to have them expand more is really important, and doing that early to allow for the lungs and the alveoli to develop appropriately.
And speaking about these kind of different instruments and expanding, I remember when I was an intern, I just thought there was posterior spinal fusion with this screws and rods. I thought that was it, and then I realized there are way more things that have been invented and used, especially for treating scoliosis. And I'm sure I missed out on a whole lot of things when we're talking about kind of the history of scoliosis. But can you kind of just take us through a history of the treatment of scoliosis? So can you kind of take us through like the treatment of it, and I guess how things have gone through time? And then I always got confused with these like the vertebral expandable prosthetic, like the Vector devices versus the Harrington rods, and what the difference was. I was always confused about those. Can you kind of just break some of these things down for us, if you don't mind?
Absolutely. We'll need more than an hour. But yes, because the history behind this, I'm kind of a nerd. I just find it so fascinating. Right. So you've got Dr. Mehta, who did the RVAD and phase ribs and the meta casting and those kind of things. And so whether you can do a cast in like an infantile kid, the infantile idiopathic scoliosis, or you can, in an older kid, you can do bracing, because what you want to do is you want to try to delay operative intervention for as long as possible for a couple reasons. And we're learning more about that now. And Dr. Sankar and then they kind of came up with the law of diminishing returns. So once you start implanting these devices, you can get good expansions, but then things start getting stiff. So you don't get as much later on down the road. And then, like I said, here then in the 60s, the Harrington rods, they placed these, actually they were special kind of Harrington rods, because Harrington rods were used for scoliosis, but then they made these special ones that were threaded. And so then they would go, and every 6 months they'd come back and they would turn some more on those threads to longitudinally expand the spine. And then, so they were doing that with the Harrington rods. And then Dr. Campbell, actually down here in San Antonio, they were looking at the issues with the rib fusions and thoracoplasties. And he just, I believe it was just like a Steinman pin or a K-wire. And he basically wrapped it around one rib, pulled it down, wrapped it around another rib, and just pulled the ribs apart. And then he
Yeah.
kept sequentially doing that every 6 months to try to get more room for the lungs and improve the FEV1 and FVC, the forced vital capacity, and all those kind of things that we've all tried to forget from med school.
Right. I was just gonna say that.
And then he developed it. There's been multiple iterations of it. Then he came out with the Vector, the vertical expandable prosthetic titanium rib. And that at the bottom right of your slide here, you see you've got the hooks at the top. And then within that that thicker portion, you've actually got an expandable. It basically they're overlapped. So there's a piece within the outer shell, and you can expand. And what you have to do is every 3 to 6 months, depending on their age, sequentially, they have to go back under anesthesia. You open up right where that area is, and you can manually expand them. And so they not only have the vectors that were made, but also traditional growing rods. And that's essentially like whenever you do a spinal fusion, you've got the rod coming from the cephalic portion down, and then the caudad portion up. They actually overlap in the middle, and there's a side-to-side domino connector. And so every 3 to 6 months, you go back and you can unlock one screw of that side-to-side domino connector and expand.
Okay.
The problem with that in both of these is, well, there's multiple that we've seen. You've got the complications right here, anchor malfunctions, right? Whether you're at the pedicle screw or the pedicles up top and the pedicles at the bottom, you're out on the ribs, which the Vector was big on the ribs. And in an SMA kid that's non-ambulatory, you can go rib all the way down to the pelvis. But if you're pushing up and putting a lot of force on those ribs, the anchors can go through the ribs. And so then you need to revise them to either other ribs or actually to the spine. You need a repeat anesthetic multiple times a year for years. And they actually just came out with a really good article about the hidden cost of early onset scoliosis. And it kind of goes into what are these repetitive anesthetics doing for the growing brain, the multiple admissions for a kid's psyche as well as a family's psyche. It's a lot to go through for years at a time. It's a significant complication rate. If you're making an incision in the same area multiple times a year, you're at risk of wound dehiscence and infection and all those kind of things. It's a difficult answer. And so then they came out with these magnetically controlled growing rods, which we're very hopeful about, where you can put the anchors in the top and the anchors in the bottom, and actually in between is a magnetic rod, much like the nail that you can do in the femur or the tibia for limb length discrepancy. You can do that between pedicle screws within the spine, and then patient comes back to clinic, you put the magnet over it, and you can just lengthen them every few months in clinic. But then you're also beholden to, if the spine's getting stiffer, is the motor going to be able to overpower the stiffness of their spine in order to expand enough to keep growing that spine? So that was the most brief I could be.
And so that last thing, those are the magic rods you're talking about?
Correct.
Those are magic rods. And so one of the things that it took me a while to understand, I just didn't realize, is that in AIS, we're talking about instrumentation where you're putting pedicle screws in the bone and you're attaching the rods to those, to those screws and getting your correction through that. But here, these are actually attached to the ribs. It's like you were mentioning, a little bit earlier, or like a rib and a pelvis. And that's kind of how you're getting, that's not fixation points, but those are kind of how you're able to guide the growth of the spine. And
Exactly. Especially in the younger kids. I like to try to stay away from the spine because I don't want that spine to get stiff. So I'll try to you can go ribs to pelvis, ribs to spine, or spine to spine. But yeah, they're all different types of anchor points.
And is there, I know earlier we mentioned some of the with congenital, the ones that have a really high progression rate. Is there any times that you would consider that you would be doing a spinal fusion in these patients that have like congenital scoliosis? I know we just mentioned we try to stay away from the spine if we can, but are there times where we should just go ahead and fuse the spine?
Um, Short answer is yes. It's really tough though. It's
Okay.
your indications would be for something that's going to be rapidly progressive, like a hemivertebrae or with a contralateral unilateral bar, or there's like at the L5, L4 level where there's a boatload of takeoff that from the lower lumbar spine that's then going to cause a compensatory curve up top. So then if you wait, you're actually going to have a compensatory curve and you're going to have to do a longer fusion than if you were able to just do a hemivertebrae excision and a
Yeah.
short segmented fusion. So I wouldn't want to do kind of like when you're thinking of AIS, am I going in that 7 to 12 level
Mhm.
range? I would, and they've come out with a paper recently of looking at single level fusion versus going 2 up and 2 down, and that it's safe to go shorter even whenever you've got the hemivertebrae if you take care of it early before there's a huge deformity and a really bad takeoff. You can try to go in and take that hemivertebrae out and then just do a very, very short segmented fusion so you're not taking away from the spinal growth, especially in the chest cavity. And
Yeah.
it's a lot safer to do a hemivertebrae excision. I say it's safer. There's significant risks involved anytime you're doing that, just due to the nature of your real estate. Uh, but down in the cauda equina area, there's more forgiveness. The nerves
Mhm.
move a little bit more, rather up in the thoracic cavity where you're working right around the cord.
And another question is, when we're talking about fusion, are we talking about, just, getting this fusing the bones and not putting metal or hardware in there, or we're just talking about just fusing it and putting metal and hardware in there, like
Um,
instrumentation?
in theory, you could do a non-instrumented fusion. I have never done that.
Okay.
I've read about it, and I
All right.
know that some of my mentors have done that. And essentially, what they would do is they would go in and they would fuse, and then they would leave a patient in a cast or a brace for 4 to 6 months to allow them to fuse. And that would be, a younger kid where you're trying to avoid having instrumentation in there.
Okay.
And so, what I've always done would be an instrumented fusion. And then another thing to think of is if you're doing an instrumented fusion in a very young kid, even if it's short segment, you get this thing called crankshaft. And that was something that they would say it a lot in residency, and I had no idea what they were talking about.
Yeah.
But what it is essentially especially in a young kid, you're stopping the growth on the back of the spine, but the front of the spine is still going to grow. So it's going to crankshaft up like that, and the front of the spine is going to continue to grow, and the
Yeah.
back of the spine is going to be tethered. So it's actually going to act like a bar, but a posterior bar instead of a unilateral bar,
Mm.
causing a Cobb angle. It's more like
Yeah.
a posterior bar, but we're creating it.
So that's why, I was reading a book and they'll say you may do like a combined anterior and posterior spinal fusion just to prevent from that crankshaft phenomenon that you're
Exactly.
discussing. I'm
Exactly. And
glad you.
I felt smart and cool saying crankshaft, but I never knew what it was until finally one day I sat down and said, you know what? I'm going to figure out what this crankshaft they're talking about is.
Yeah, yeah. No, I just learned it today, just now. That was great. All right, cool. That's awesome. That was a good overview of all, some of the history and the different instruments that can be used for these patients. And so maybe we can talk about like, so what is your treatment algorithm for congenital scoliosis? And we kind of just discussed a little bit about this already, but maybe I guess for repetition's sake, we can discuss it pretty quickly, and then we'll talk about the treatment for infantile scoliosis next, and go from there.
And honestly, when it comes to congenital scoliosis, I try to do nothing
Okay.
until I have to do something, right? You do the appropriate imaging, the appropriate workup. Bracing doesn't work, right? This is a bony deformity. Casting doesn't really work. This is a bony deformity. Whenever you want to do a brace or a cast, which I have done before in these kids, is whenever there's a compensatory curve. So, right, you've got something going on. Let's just say you've got something going on in the thoracic spine. Their lumbar spine, their bony anatomy is normal, but they're trying to stay balanced. So a lumbar curve is happening. And that's more of like the idiopathy where you can throw a brace on to try to prevent progression of the compensatory curve. But then once they start getting that takeoff is where they're going to push you to do something. And that's whenever you have here, ideally you get them to greater than 10 years old before you have to do anything. Some people will go down to 8 years old. I try to stay conservative and get them into double digits. And so you can do a isolated posterior fusion. Because if you're getting younger, then you're worried about that crankshaft and where you would need to go anterior and posterior. And then the hemivertebrectomy can be controversial, right? You can do the early ones, especially if it's a young kid in a really bad area where they're getting a lot of takeoff. You can do a short segmented fusion with a hemivertebrectomy. Or I use it if they've got an isolated curve that's throwing their balance off, their coronal balance off. Then what I'll do is I'll do a hemivertebrectomy, and I like to actually go in and go down the pedicle on that one hemivertebrae. And what you can do is you can put an awl in there and use that in order to kind of free and use that as a joystick almost. And then you can shell out that hemivertebrae and take out as much as you can, and then compress down and bring that down.
Oh, that's pretty cool. I've never seen one.
Yeah, and that's why I try to wait until if they'll let me, if their body will their spine will allow for you to wait, then I try to get them to greater than 10 years old.
Okay. And I mean, I guess that's kind of somewhat similar with infantile. Some of the numbers that they ask us, are there any numbers where you're like, this angle is this degrees, like we should probably go ahead and do this instead of waiting?
Yes, whenever you get to, like you have here, whenever you're getting to 30 plus degrees is where I want to get them in a cast when it comes to infantile idiopathic scoliosis. And when it comes to casting, we do the metacast, or that wrote on the Risser table. I don't know if you've seen one of those. They're pretty interesting. How it happens. But that's whenever I'm thinking cast, and then I'll change the cast 1 month for every year of life. So if they're 3 years old, let them be in a cast for 3 months. 2 years old, 2 months. 1 year, 1 month. But like you have here, there's concern with multiple anesthetic events, so you're trying to hold off for as long as possible. I try to do that before ever jumping into any kind of surgery, because if you can get that Cobb angle down, like you have here, that's a beautiful progression of scoliosis to in cast to out of cast. You've got a nice straight spine. But even if you can get good correction, or at least improvement, and then you've bought yourself 6 months, a year, that allows for you to get a little bit more real estate if you need to place pedicle screws and magnetic rods, and it pushes you out and makes the anesthetic slightly safer.
Yeah. No, this has been great. I definitely learned a lot about I guess early onset scoliosis, but then congenital and infantile. Is there anything else about maybe juvenile that may be any different at all that you may your algorithm may change by any chance, or is it kind of somewhat similar? Still try to get them to double digits and then maybe just do a posterior spinal fusion if you can.
Mhm. You try. Sometimes it just doesn't work. My algorithm's slightly different. I don't go and do casting.
Okay.
I will do bracing. And so they've got multiple different kinds of braces. But I'm pretty aggressive when it comes to bracing. So you get your MRI. I do not have casting really in my algorithm of a 6 or a 7 or an 8-year-old, but I am very aggressive when it comes to bracing. So I definitely try to get them in a brace greater than 18 hours a day. But then sometimes that curve's just significant, it's refractory to bracing, it's going to be progressive. And that's whenever I try to do the magnetic controlled growing rod. Because I want to give that an opportunity to fail. Because majority of the time, if you get them to be an older kid, then it's going to work, and it's going to work for a couple years, and then you're going to do a definitive fusion when they're 10, 11, 12 years old. But sometimes it doesn't work, and sometimes you have to bail out to traditional growing rods or something of that sort. But unless they've got a severe kyphotic deformity, or their soft tissue envelope is not going to allow for them to take a magnetically controlled growing rod, because they're very thick, because they have to have the magnet and the motor and everything like that. And so those kids with not a great soft tissue envelope, sometimes you might have to work with your plastics colleagues for some tissue expansion. But yeah, those would be the reasons why I would not try the magnetic rod first. But the big one is kyphosis.
Okay. All right, cool. Well, again, Dr. Landrum, I think this has been great. You know, we discussed multiple different topics, and even we talked about the history of treatment. We talked about what to look for on imaging, what to look for on MRIs, different algorithms. Is there anything else about, early onset scoliosis that you want our listeners to take home, or anything else that you'd like to mention before we wrap up?
From my standpoint, I find it fascinating because we don't have this completely figured out yet. And there's other techniques that we didn't even talk about today, like the Schiller technique, that they're still kind of in their infancy and they're developing. But I just think that any bright, interested individual, please come and hop into any of the study groups and try to figure out how we can best help these kids. I find it fascinating and difficult.
That's awesome. Well, Dr. Landrum, again, thank you so much for coming on the podcast. It's been a pleasure talking to you and having you on. For those that are listening, that can follow you, where can they follow you at? If you want to follow you on Twitter or wherever, how could they see what you have going on?
So I do not do much online, but I do have a Twitter. It's at Matt Landrum MD. I had to just look that up because I get on there and I follow a lot of journals and actually a lot of LSU sports and MMA. But you can follow me there. I don't post much, but I do look at and try to keep up to date with things.
Yeah. Did you watch this? Etiology Purified last weekend?
I sure did, and actually I was there. For their first one in Madison Square Garden,
really?
when it was them, and then you had Dustin Poirier and Michael Chandler fighting.
Yeah.
So I was there for the first one, but I did get to watch the rematch this weekend.
Oh man, that's awesome. Yeah, I watched. I'm a big MMA guy too. Well, again, thanks so much for coming on the podcast. Those that are listening, please hit the subscribe button, leave a review, let us know how much you enjoyed this episode, and we will see everybody next time.